Hello, a very good afternoon to everyone present here. Good afternoon, ma'am.
Good afternoon. Can you hear me?
Yes, ma'am. Can you hear me?
Uh, Yeah, I can hear you very clearly.
Uh, a very good afternoon to everyone present here. I am Abhinav Fufalia, MHA first year student at Prasanna School of Public Health, Mahi, Manipal, India. It's my honor to welcome all the participants from 25 different countries to benefit from, from the webinar. Organized by the Manipal Health Literacy Unit, known as MHLU, in collaboration with Monash University, Malaysia, and the University of Haifa, Clat Health Services, Israel, jointly organizing a free webinar on the health literacy for healthcare providers, researchers, policymakers, industrials, academia, and the public. Before I introduce our public webinar speaker for today, I would like to make some important requests to all the participants. A small request for distinguished participants to kindly mute their cell phones and mic. You may post any questions during the session through the chat box. We will be addressing a few selected questions considering the time limitations. In today's webinar, we will be hearing expert insights on a data analytic roadmap to health literacy assessment and health literacy information intervention for population health. Please note each speaker will be sharing their insights for 15 minutes. Ladies and gentlemen, please allow me to introduce Professor Tintin Su, a public health physician and researcher with over 2 decades of experience. Professor Su groundbreaking work span community capacity building, social epidemiology, and implementation science research. As a director of Southeast Asia Community Observatory (SIACO) Health and Demographic Surveillance System, she oversees a cohort of 38,000 individuals, facilitating comprehensive research on population health. Notably, Professor Su is a leading figure in health literacy, having received international recognition and awards for her contributions. Her research interest encompasses climate change, impact on non-communicable diseases, digital health applications, cancer screening, and public health program evaluations. With funding from esteemed institutions like the Wellcome Trust and the World Health Organization, Professor Shu's work continues to drive meaningful advancement in public health knowledge. Please join me in welcoming Professor Tintin Su, whose dedication to improving population health, particularly through her work on health literacy, is truly commendable. Over to you, ma'am.
Thank you. Thank you so much for a very nice introduction. So allow me to share my screen. Can you see my screen? Hello? Can you see my screen?
Sorry, ma'am, I'm not able to hear you.
Hello? Can you hear me?
Yes.
Yes, ma'am.
Yes,
Now we can hear.
Okay. So can you see my screen?
Yes, ma'am.
Yes, we are able to see
Okay.
your screen.
Okay, thank you so much. So I'm going to proceed. So good afternoon, good morning, and a good day for everyone. I'm sure everyone joined to this seminar is across the globe from the different time zones. So thank you so much for inviting me to share research finding to this webinar. So I have several health literacy informed intervention, but today I want to share a piece of research on colorectal cancer screening intervention in Malaysia. We call it CRC-SIM. Before I proceed my presentation, I want to acknowledge CRC-SIM research team from Monash University, Malaysia, Queen University, Belfast, and then also Ministry of Health, Malaysia. And then I want to thank Ms. Kogila Ramadan for preparing some of my slides and CECO-FEED team and Community Engagement Committee, District Health Office, Sagamat, and participants of CRC-SIM's interventions. And they're also funders. This research is funded by Medical Research Council UK, MRC UK. So colorectal cancer is the most common cancer among men, and the second common cancer among women. And then it is the top 10 leading cause of death. Actually, colorectal cancer can be, the survival rate is good if the cancer is diagnosed in the early stage. So survival rate is around 72 to 75% if the cancer is diagnosed in the stage 1 and stage 2 early stages. But unfortunately, in Malaysia, colorectal cancer cases are diagnosed late. About 70% of cases are detected at stage 3 and stage 4. So there is a screening for colorectal cancer. In the resource-limited country, fecal occult blood test is recommended as the first choice for colorectal cancer screening. Screening with the FOBT reduces the relative risk of colorectal cancer mortality by 16%. And in Malaysia, the immunochemical fecal occult blood test, IFOBT, is recommended as a suitable screening test. But there are some issues in colorectal cancer screening, particularly inadequate colorectal cancer screening coverage for the targeted or eligible population. So in Malaysia, we only reach less than 3% of eligible population to be screened for colorectal cancer. There are limited awareness about colorectal cancer and barrier for colorectal cancer screening among Malaysians. And there is a need for a systematic research approach to enhance the screening update among the eligible population. And then we applied this grant before pandemic. And then once we implement that research, it just coincides with the COVID-19 pandemic. So we also need to consider COVID-19 pandemic impact on colorectal cancer screening. So this is a step we design and co-create the intervention. So our intervention is evidence-based, and it's a culturally sensitive or context-specific and health literacy-informed information. I'm going to explain step-by-step, how we design and co-create the intervention, including all components like, evidence-based, culturally sensitive, context-specific, and health literacy-informed intervention. So first, evidence-based. So we try to gather evidence across the globe, and then we learn, what is relevant for Malaysia, what is relevant for our intervention. So we did the scoping review, and then we started, we used such terms, and then we hit around 4,000 published paper. And then after title screen, abstract screen, and then full text screen, finally, we included 41 articles in our scoping review. So among the 41 articles, 26 articles came from 24 studies, and then policy review and commentaries are 15. So we have already published scoping review protocol and the results of the scoping review. In summary, 24 studies were implemented in 9 middle-income countries, and 11 population-based screening program and 13 small-scale screening intervention. In nutshell, educational interventions combined with the screening seems to be the best strategy, which achieve a 65% coverage in the low and middle income country. But however, the FOBT and colonoscopy uptake range from 14 to 100%. And the most commonly reported implementation indicator was uptake or reach to the population. So second, culturally sensitive, context-specific. We include views and preferences of community members and key stakeholders for our CRC screening program. So we conducted 11 focus group discussion with 89 community members, including Malay, Indian, Chinese, male and female views and opinion. And then we also did an individual interview with 24 stakeholders. And then we came out with prototype of our interventions. And then we did the expert panel discussion to take opinions from the expert panels to amend or to adjust our intervention to suit with population.
There is no deadline, right? Before 12.
Sorry.
Question ka? I mean,
Sorry?
Iska.
Sorry, should I proceed?
4 baje. Right. So 3 baje.
Hello, can you
2
please
baje.
switch
ठीक है, 2
off your
baje, 2
mic?
baje. Before 12.
Sorry, ma'am.
Can I proceed? Okay.
Yes,
So, so this is the findings of our qualitative study. They are community level inhibiting factors like a low awareness of colorectal cancer and screening, and then some emotional barrier like disgust of stool collection, and then fear of test results, and financial concern. Although IFOBT test is not expensive, people are afraid, to do the colonoscopy because it's quite costly. And then transport, to go to the screening center, health clinic. And then we also ask, if you receive the screening test by post. I mean, they are a bit concerned about postal delivery of specimen and then test results. And then last but not the least, a literacy and language barrier of information. But there are also some facilitating factors, particularly community really trust in the doctors. And then they say the doctors can address negative perception towards stool tests and then cancer screening. There are also some health service barrier like limited budget for colorectal cancer awareness activities, understaff, and availability of IFOBT test kits, and then long waiting times in the clinics, and then very limited time for doctor-patient's communication. But there are also several facilitating factors for health service, particularly doctors are very good in doing patient navigations and collaboration with the different department. And then they can reduce waiting time for patients because a health clinic, they have a dedicated counter for colorectal cancer screening. So this is a health literacy definition. The health literacy is a person's knowledge, motivation, and competence to assess, understand, appraise, and apply health-related information in order to make judgment and take decision in everyday life concerning healthcare, disease prevention, and health promotion. So our intervention target to support the participants assess and understanding of colorectal cancer and their screening, and to appraise risks and benefit of the screening, and then applying their knowledge to involve in the testing of their stool for the colorectal cancer screening. So this is the overview of the screening program. So during the pandemic, we try to reduce a face-to-face contact. So we have a participant's telephone number in the SIGO database. So for people who are in 50 or 75 years old, we randomly select, and then we make the recruitment call. Our trained data collector make the recruitment call, explaining colorectal cancer screening, and then the program. And once the participant say they agree to participate, and then we send a colorectal cancer screening pack. So that screening pack includes the invitation letter. It is a personalized invitation letter, and then explanatory statement, and then brochure. And then we include stool collection container. And then also this is a test kits. And then we include masks, glove, and then also biohazard disposal plastic bag. And then we sent the whole package through courier service. And after that, after 2-3 days, a data collector sent a video by using either WhatsApp or Telegram. So this is a IFOBT instruction leaflet, English version. Actually, we produce English, Malay, Mandarin, and also Tamil, so full version of the brochure. And then we include, all information, what is the normal test results, what is the abnormal test results, and then the contact telephone number. And then also we make sure who are the research team members. So SIGO, Monash University, Queen's University of Belfast, and then who is the funders. And then we collaborate with the Ministry of Health Malaysia. So we include a step-to-step guide how to do stool tests. Even we include, to wash their hand, how to sit on the toilet seat, so on and so forth. We really give a detailed step-to-step guide to conduct the stool test. And then the participant can screen the QR code to look at the online video. So according to our focus group discussion, the community trusts on primary care provider, particularly from Ministry of Health, so we approach primary care provider, the doctors from the health clinic, from the Sagamat district. And then we have one Malay doctors and one Chinese doctor. So they allow us to do a video, and that video include colorectal cancer, what is a screening test, and then the benefit of the screening, and then again, step-to-step guide to do a screening test. And we have a Malay version by the Malay doctors, and then we have a Mandarin version with a Chinese doctor, and we cannot manage to find an Indian doctor. So what we did was, my PhD student is native Tamil speaker, so we use this video and then dub with Tamil language. So we managed to send the video according to the ethnicities of the participants. So after sending screening pack and video, after 1 week, we send the reminder text message. And once the participant complete the IFOBT and then send a photo of the test results to SICO, two researchers from the research team with a medical background review and share the results with the participants within 7 to 10 days. If participants didn't send or didn't complete the IFOBT, and then data collector make the reminder call, and then if reminder call to complete the test, but if participants didn't complete the test, we stop communicating with the participants, and then we try to get follow-up call, to know why they didn't participate in the study. So once we get the test result, we send the text message to the participants if the results is normal. So if results is abnormal, we didn't send the text message, and our trained data collector call to the participant and then explaining about the test results. And then we give the referral letter to go and see the doctors in the primary care clinic. So our intervention took 8 weeks, and our inclusion criteria, men and women aged 50 to 75 years. And then people have a registered mobile phone number with SICO, and then they have access to smartphone and WhatsApp application. People who has a history of colorectal cancer, and then they are experiencing colorectal cancer symptoms at the time of recruitment. We don't include in the study, but we ask them to go and see the respective clinics. So in recruitment, we have a 52% of our target population.
Sorry to interrupt, ma'am.
Agreed.
It's a little reminder on time.
Okay, so now how many minutes I have?
Ma'am, 2 minutes, ma'am. More 2 minutes.
2 minutes. So I have several slides. So generally, we receive 311 IFOBT photos. So that means 42% completion rate. And then among those participants, 294 has a valid test results. So generally, we have a positive review and positive acceptability of our study components. And then 79% of participants are satisfied with the colorectal cancer screening study. So there are a lot of, positive opinions, but of course, they also have some worries about anxious and waiting about, IFOBT results, the fear of testings, colorectal cancer screening, so on and so forth. So in summary, there was a first study in Malaysia to implement home-based colorectal cancer screening tests. Our findings suggest that 52% of target population agreed to participate for IFOBT screening, and 42% of those who decided to participate completed the test and then sent a photo. 94.5% of those who complete the test managed to perform a valid test, and the intervention can support participants assess an understanding of colorectal cancer and screening information, appraise the benefit of the screening, and apply and perform the valid test. So we managed to publish the 7 papers, so you can get that paper through this website. And last but not the least, there will be a second Global Health Literacy Summit in September. 18 to 20 September in Rotterdam, Amsterdam. So currently we are opening abstract submission. So abstract submission deadline is the 15th April. So hope to see many of you who are interested in health literacy in the Global Health Literacy Summit. Thank you so much. Sorry for taking a little bit time.
No problem. Thank you, ma'am, for sharing your valuable insights on the topic. Now I'd like to introduce, please welcome Dr. Vani Lakshmi, ma'am, an accomplished assistant professor at the Prasanna School of Public Health, Mahir Manipal, with a gold medal in MSc Statistics from Loyola College, Chennai, and a PhD in Statistics from Pondicherry University. Dr. Lakshmi's expertise extends to applied statistics, data analytics, biostatistics, and more. Her academic powers is complemented by an MBA in Quality Management from BITS Plani, and she holds on certification as an ISO 901:2015 QMS Leader Auditor and Lean Six Sigma Black Belt. With over 40 publications and a passion for continuous learning, Dr. Lakshmi brings a wealth of knowledge and experience to our discussion today. Let's warmly welcome Dr. Vani Lakshmi, ma'am, as our second speaker.
Thank you very much for the invitation, and I hope I can share my screen. Yes, can I? Yeah.
Yes, ma'am.
Yes, ma'am. Can share.
Thank you. You could confirm once the screen is visible.
Yes, ma'am, it's visible.
Yes. So I hope all of us have had a very insightful discussion, short but very sweet and very impactful. Thank you, ma'am, for giving us the insights. So now, as you are aware, we are going to have a very short, crisp discussion on the data analytic roadmap towards health literacy assessments. I'm sure any discussion on health literacy assessments or awareness per se will have some numbers at play. Okay, there will be definitely a reference to a software, some techniques would be introduced. So there is definitely data analytics that is going to be there with you as you develop a health literacy assessment tool. So instead of giving this long and perhaps tricky and very professional title, I would want to rephrase my talk to be, just a minute. My screen is visible, no? Yep. Yeah. So I would like to title this talk as Hindsight Wisdom for Health Literacy. Some insights I wish I had when I began being part of amazing teams that have come up with health literacy assessments, both within MAHE and beyond. So I consider this to be a mutual learning space. You feel free to connect and discuss, and I see a few of us embarking on a health literacy journey together. So this is a question for you. I'm sure you could use the chat window. So where do you think a statistician or a data analyst or a data scientist should be involved in developing a health literacy assessment? You have options. You could put A, B, C, D, E, F, G. Okay, if you think it's none of the above, you could write none of the above. If it's all of the above, you could write that as well. So options are A, B, C, D, E, F, G. I would wait for a couple of responses for sure, and I request the MHLU team to support me in getting access to the chat. I'm just ensuring that you are with me as we talk and discuss.
Yes, ma'am.
MHLU team, do we have a couple of responses? Yes.
Yes, ma'am. From Aditya Tanwar, he's saying CDF.
Okay. Okay, C, D, and F. All right. One more, maybe. You could focus on the highlight I have clearly mentioned. Passionate statistician, okay? Yeah.
And now it's from Professor Diana. She's saying all.
Okay. All right. So since we are running short of time, I'm just going to stick to these two responses. The right answer is actually all of the above. Okay, so I'm going to tell you why and how in another 1 minute. So when you're developing or when you're working towards developing a health literacy assessment tool, you will have a research problem at hand. Like you would want to assess literacy levels for a specific area, let's say mental health, for a specific age group, let us say adolescents, in a specific setting, maybe in a country or in a state or in a district, howsoever you would want to do. So at that point of time, as seen in our previous discussion, perhaps you would do an extensive literature review. You might come up with a scoping review or a systematic review, identify areas based on existing literature. You might talk to a lot of people, a lot of experts in that area, and then start ideating the structure of the questionnaire. A statistician appears here to make your life simple. Maybe you could think of a yes/no question depending on the context, the setting, okay, the kind of question you're trying to address, okay. Maybe it's a yes/no questions, a collection of yes/no questions. Maybe it's a collection of 5-point Likert scale based questions, okay. So maybe it's open-ended questionnaire and a qualitative research would sound a better idea, okay. So depending on the nature of your objective, your audience, and your purpose of developing a questionnaire, in the very first phase of this particular research, a statistician could help you. Okay. Now, when it comes to the second step, sometimes, okay, all of us are experts in our own area of research, but sometimes you need a different lens, somebody who's part of your team who can critically review your work and ask you questions like a layman and help you find solution as well. That is where a passionate statistician would come in. Simple phrases might make a lot of difference because you might be an expert in mental health domain, or maybe you might be an expert in giving awareness relating to a specific kind of cancer, to be precise. So you may have a lot of things, but you need somebody in your team who would think like a layman. And statistician and the linguist, the language expert, are two people who will give you that flavor of how a layman would probably understand your statements. Sample size computation is a very, very technical term, so it's pretty clear that a statistician is going to be there. Finalizing the methods, yeah, the moment you see analysis, yes, the methods to be chosen, definitely a statistician is going to be there. Helping you by giving you a nice collection of data collection mechanisms and coming up with a nice plan to collect data. That is also a place where a statistician could help. Data analysis, of course, I would say, and dissemination of findings. And if you look at it, these are all indirectly steps in the development of a questionnaire. Now, when you think of developing a questionnaire, there are two terms that come to your mind. One is reliability of a questionnaire, and the second one is validity of a questionnaire. So there are a lot of terms that keep coming when you do literature review. I am just going to quickly tell you what they mean, and I do have my share of references for you so that you can have a follow-up discussion and deliberation for your extensive research activity. So validity, it's just like validity of your mobile SIM. If you are having a prepaid connection, you might pay some money to extend the validity, right? Why? Because you need to call, you need to use the internet, right? So similarly, validity of a questionnaire is, okay, this questionnaire is developed for a particular purpose. Will it serve my purpose? Okay, and validity is an area where you will bring all your experts on board. We will talk about that in detail. The second part is reliability. So validity is done before your questionnaire, at least some part, except the construct validity, the conversion, and the discriminant. Phase and content validity are actually done before your questionnaire reaches its intended audience, whereas the last four require some data to be actually taken from the intended participants. Phase and content validity are two areas where you would require your expert support. We will talk about it. The second word that rings your bell is reliability. You know, is my questionnaire going to generate scores consistently? Okay, I could think of a simple example for you. Suppose you are having a statement, you're trying to assess, let's say, literacy in knowledge of science among primary school students. And wherever you go, all students are giving correct answer to this question. Sun rises in the east, true or false? All students, anybody whom you meet, classes 1 to 4, meaning students aged less than 8 years, they are answering this question correct. So what do you learn from that? It means it's a universally accepted truth, and perhaps kids are seeing it. Kids are seeing a sunrise, and it's very significant culturally in an Indian context. So it may not be a good true or false question. So that is a place where the question is too consistent. It is no longer, it is giving you constant results, right? Everybody is giving right answer. But what are we expecting, especially in studies where literacy is there, where assessment of practices and beliefs are there? We are expecting variability in responses. At the same time, we want our people to understand what the question is and give the appropriate response. That is what I refer to by the word consistency of the questionnaire. Okay, so reliability is another area that is most important when you are designing, developing, validating, and then reaching out your questionnaire to the masses. So face validity in simple terms is, does it look like it measures what it really claims? Okay, my questionnaire is supposed to measure mental health literacy, but is it really doing its job? Okay. Content validity, does it really have all the important aspects or dimensions of mental health literacy? Okay, among adolescents, let us say. So these two aspects are done in the design phase. Yes, you will definitely have a statistician and a language expert on board who would guide the research team to phrase items or questions in a manner that it caters to the different socio-demographic aspects of our study population. Okay, next you have criterion related validity, okay, or concurrent validity, construct validity, convergent validity, and discriminant validity. These are 4 other validity measures of which we usually tend to choose 1 or 2. And if you look at literature, construct validity, if I tell you the term, you will know. Exploratory factor analysis and confirmatory factor analysis are statistical techniques that will actually tell you, is the questionnaire really capturing what you theoretically proposed and then expressed in terms of items in the questionnaire? Okay. So not all of this need to be done for all questionnaires that you develop. As a research team, we need to take a call on what matters to us and what really doesn't. And I'm going to tell you an example in my upcoming slide. So in the next slide, we would be discussing reliability measures. I'm sure that if I tell you Cronbach's alpha, you will quickly realize that we are talking about reliability of a questionnaire. So do all the questions measure the same thing? Are my responses consistent with what I aspired for when I developed the questionnaire? Yes, your Cronbach's alpha measure will tell you. But then all of us are trained to remember that Cronbach's alpha, okay, do take a software, run the analysis, get the data. Go meet 50 people, get the data, run the analysis, and if your Cronbach's alpha is 0.7, then you are successful. But that is not the case. Okay, a Cronbach's alpha, as much as it's more than 0.6, is considered to be satisfactory. So we need to really review each of the approaches and try to understand, okay, is this acceptable? Can I go ahead? You need to really see. Test retest reliability is another thing, another aspect, not a thing, it's another aspect that people look into to address the question, do people give similar answers if asked again later? But test retest reliability is a little tricky situation when you look at health literacy assessments, because of the fact that our population might memorize or find out the right answers thanks to generative AI. Even Google has now taken a backseat. So people tend to Google up and find out right answers and also memorize them. So we might have a misuse of test reliability in the coming days. So we should be very cautious in fixing the time gap between the first response of the respondents and the second one. And we are expecting test reliability to be pretty high. There are a lot of measures depending on the kind of questionnaire you are building. Inter-class correlation coefficient is one of the measures which is used here. There's also something known as alternate form reliability, where you have two different versions of the same questionnaire. You would be giving it to the respondents and you will try to see whether they give similar results. Okay, so these are, I have just briefly touched upon the validity and reliability aspects of questionnaire development, because I am very much aware that a lot of people are enthused about developing their own questionnaires. Now, moving on to two important elements that we come across as non-native English speakers living in different parts of the world. The first aspect is cross-cultural adaptation. A lot of us Google up, explore PubMed, find a method that will suit our need and quickly initiate the steps, and then quickly cross-culturally adapt the questionnaire. But the fact which I would like to highlight here is, and even give to you as an open problem, is this is an article which I picked up. Sorry. This is an article which I picked up this morning, and I realized that there are a lot of guidelines for cross-cultural adaptation of questionnaire, depending on different countries, depending on different study populations, depending on different aspects of health literacy and beyond. And there is no general consensus on what is the best methodology or guideline to follow when you look for cross-cultural adaptation of a questionnaire. In simple terms, it means that maybe a questionnaire is developed in French, but somebody is doing a study in India, so they would want to, adapt the questionnaire to an Indian setting. It could also be a questionnaire in English itself, but meant for population living in the US. And we Indians are culturally a lot different when compared to somebody living in the US or the UK. So we might look for. Yeah, I have 2 minutes, I guess.
Yes.
Yeah. So cross-cultural adaptation is definitely an open question, but I found this interesting article from an international journal of nursing practices, which spoke about a model of equivalence, which I felt should be part of adaptation of a questionnaire. The next idea which I thought I would be able to cover in depth is the translation element of the questionnaire. All of us use different kinds of models to translate a questionnaire. Here I have 2 references for you. I particularly enjoyed the TRAPD model because the adjudication step really emphasizes on the role of a statistician and a linguist in translating a questionnaire from a language to another. So I really hope that you would look forward to exploring some of these aspects that we have discussed today. I also want you to get introduced to a software called Jamovi. Okay, I just presented a screenshot with the complete realization that I may not be able to cover a lot of aspects. So Jamovi software is a freely available open source software which will give you a lot of options to assess reliability, validity of the questionnaire, whether you're doing a cross-cultural adaptation, whether you're doing a translation. All forms of reliability and validity related aspects are covered in this particular software. It is built on R programming language, and it is a free open source software with no requirement for you to learn coding. I would just quickly go through the key takeaways for my discussion. It's good that we embrace technology and generative AI, but remember that your passion to make a difference cannot be replaced. And as a researcher, we need to clearly understand that health literacy, e-health literacy, or m-health literacy, none of this are the same. So we should exercise care while making a questionnaire for any of these aspects or adapting a questionnaire for all these 3 aspects. Questionnaires which are, given to participants online and offline are not the same. So even when you're using an existing questionnaire, when you send it across online, There are a lot of factors which you need to consider, including the fact that in the context of literacy, people could Google up and find answers and perhaps inflate the literacy levels. That is something we need to be very cautious about. It is okay to go multilingual rather than developing a questionnaire in English and then translating and then, having a series of papers. You could think of a multilingual questionnaire per se. It is important for us to know the pulse or socio-demographics, I would say, of the intended audience. For example, a questionnaire developed for employees may not, on work satisfaction, may not suit somebody who is towards the end of their retirement in their professional career. And it is also important for us to never underestimate expert review and have true experts who are really enthused about your work as much as you are in your team. The role of mixed method research, which you also saw in the previous discussion, as well as the scoping review element in shaping up the questionnaires, is too crucial because it adds a lot of value because you are able to think like many researchers across the globe. Literacy assessment should not stop with a copyright or a publication. There is a scope for continual improvement. I see all of us as advocates of health and its multifaceted elements. Mere assessment is not enough, and all of us should think of what's next after health literacy assessment. It's also important for us to build passionate teams at work where all of us are on the same page and we are enthused about making a difference in the lives we care. Thank you, one and all. I know I was pretty fast, but then see, I was alerted by the time restrictions. Thank you for joining us at different time zones and for your patience. I am open to questions. And I hope I could light up your life at least for a few seconds.
Thank you, ma'am. If participation has their question, they can write it in chat box. Now I would like to invite Professor Dr. Diane Levin-Zimmer, PhD, MPH, MCHES, a distinguished professional in the realm of public health education and promotion, particularly within the context of Israel, holding the esteemed position of National Director of Health Education and Promotion at Clegg Health Services, alongside with a role as a full professor at the prestigious University of Health School of Public Health. Dr. Levin-Zimmer demonstrates extremely expertise and leadership. Furthermore, her pivotal role within the Israel Ministry of Health as research co-chair of the WHO Asian Network of MPOHL underline her significant contribution to global health promotion strategies. As a panel discussion moderator, Dr. Levin-Zimmer profound insights promise to foster enlightened and productive discussion. Over to you, ma'am.
Thank you very much. Can you hear me?
Yes, ma'am.
Thank you so much for that introduction, and thank you both for the wonderful, the two speakers, the wonderful presentations. I took lots of notes and I learned so much from both of you, so thank you so much. So let's see if there are any questions from the audience in the chat. If not, I have a list of questions as well, and we will take 10 minutes, a little bit more to have this discussion. So let's just take a minute to see if we, at this point, receive any. In the meantime, let me ask a question, and then we'll see if the audience wants to ask any more. Dr. Tintin, thank you so much. We're close colleagues. We've worked together for many years, and this was just a wonderful opportunity for me to learn about your work on colorectal cancer. So I have a question for you. We know across the international work that's being done on colorectal cancer that there is a very special challenge that many people, a huge percentage of people who have a fecal occult examination that's positive do not go on to do colonoscopies. Something like 30 to 50% of those who receive a positive result will not go ahead. And I think this is a huge challenge for health literacy. So maybe you can briefly reflect on it. I'm sure you've also thought about this. And do you have any brief insights about where maybe health literacy can help us see the process through?
Definitely, Diane. So can you hear me?
Yes.
Yeah, so I think health literacy is really important from each and every steps, So first steps, doing fecal occult blood tests, even that is, really challenging. It's a big barrier. For example, Malaysia, like upper middle income country, you don't believe it, around 3% population coverage of colorectal cancer screening. And then again, even study findings, people, we have, I think 56 as a IFOBT test positive, and then I think around 30, they didn't go and see for the colonoscopy. So I think one reason is that, they don't have any symptoms. So because normally the screening is done for the asymptomatic population. So even we ask the questions, why you didn't do the screening tests? Why you didn't go and see the doctors to do a colonoscopies? We don't have symptoms. We are healthy. So they don't really think, this is a need to go and see the doctor. So I think the health literacy come into very important components. What is the screening? What is the risks and benefits of the screening? And a lot of people still have a misbelief. You don't need to do screening if you don't have a symptom. So I think health literacy play a really, really important role in the steps of, start doing screening. Even the screening test positive, my people don't go and see the doctors to do the colonoscopy. So another one is maybe a cost. I think the colonoscopy is a little bit, costly. And then also it is, invasive. So some people are very scared of doing a colonoscopy.
Yeah.
Did I
Thank
answer
you.
your question?
Yes, absolutely. I think it's a really important challenge. I don't think anybody has solved it. So I mean, it's something we can think through together and do some international work on this, because it is really a global issue. Interesting, and I think we have to solve this, and health literacy can probably contribute. So a question to Dr. Vani. Let me see if there's anything in the chat right now. Okay, so if not, I loved your presentation. I've been working for over 45 years in health promotion and public health, and I think your presentation was so valuable. I don't think I've heard anything so concise and so passionate in such a short period of time, so thank you so much for that. I think there's a very interesting question that comes up when we look at the cultural aspects. When you talked about the intercultural aspects, often we do work kind of technically. We'll do a translation and a back translation and maybe compare different countries, but don't really go into depth as far as cultural validity. Can you reflect on maybe how, especially when you're passionate, which is so important, how that passion can carry over to doing something a bit more in depth for cultural adaptation of questionnaires? I think there we need to really reinforce our skills.
Thank you for the question, and thank you for being with us today. So to address this question, I can quickly think of a tip that I usually tell my research teammates. So let's say we are doing a technology literacy assessment. I'm just shifting from health for teachers, for school teachers in the post-COVID era. I'm just diversifying the space. So at that point of time, to the research, to a team that I was working with, one thing that I told is, do you know someone in your family who's a teacher? And you may not include this person, you should not include this person in the final study. This person may not be even listed as an expert member, but if you can, you should. But can you just discuss, do not ask the teacher to answer the questionnaire. Ask that person, are you understanding the questions? Is it matching with what your expectations were when you heard about my study? And sometimes, especially when we deal with sensitive topics, could be substance abuse, mental health, anything related to gaming disorders. So I think this is the secret step that really makes a difference, because we are experts. We would have read a lot about it, but we don't think like an adolescent who's 13-year-old who's having a lot of screen time, or we wouldn't think like a teacher working in a rural setting, trying to bridge between Microsoft Teams, learning how to make a PowerPoint presentation. So we need to really get what they really think. And that input has actually helped in a few studies that I'm part of. So this is one quick tip that I can tell you at this point.
Thank you very much. So you're really supporting the idea of co-creation, of working with our target groups when we develop our tools from the start. So the passion that you talk about has to be carried over to even go outside of our comfort zone, which is within our team, and go outside and go into the community to check our tools before we do anything quantitative.
Yes.
So thank you very much. I think that is a really important message. Let's go to our chat and see if we have questions there, or if we have questions in our Q&A. I don't see them right now. Okay. So I'm going to keep the discussion going if it's okay. So Tintin, going back to you, Professor Tintin, when we talk about early detection, because colorectal cancer is early detection, as coming off of, again, the comments that Dr. Vinny just made, when we look at cultural aspects of early detection, you mentioned the issue of symptoms. Do we have to do more work also with our primary care providers to make sure that they themselves believe in the tests, their health literacy about the tests, their way in which they feel that they have the ability to convince their patients and their community and get them on board more? Is there more that we can do to include them? Or do we feel that we've really gone as far as we need to, and we have to look at other areas of intervention?
Thank you, Diane. So it sounds like you read mine. So actually, we have conducted, several studies in the cancer, so breast cancer, colorectal cancer, awareness raising campaign, and then also now this is a screening intervention. And then what we found out is the community really believe in the doctors, although they have a low awareness, barrier. I mean, transportation, emotional barriers, practical barriers, so on and so forth. Everyone's, almost everyone said, if the doctors, can talk to us and then explain and navigate, many people would be willing to do. So, of course, there are also health service barriers. So the doctors are also willing to talk, but particularly in the government, a primary care clinic. So it's very long queue, many patients. So they only need to do what they can do within the limited time period. So, for example, once they come and see opportunistic screening, if people come and see the doctors for hypertension, then the doctors need to ask if it is, in that age range. Oh, have you ever done colorectal cancer screening? Have you ever done, breast cancer screening? And then recommend, to do a screening. But unfortunately, it's because of the limited times and the other barriers, cannot do. So now our target is the primary care provider. So we are doing a systematic review on the role of primary care providers in navigating cancer early detections and screening. And then also we are going to do individual interview with the primary care providers, and then, how we can improve, that situation. It seems, primary care provider roles are really, really crucial to increase a screening coverage rate, and then also navigation, improving awareness. Thank you for raising this one. So it is very much in line with what we are doing and then what we are thinking. Thank you so much, Diane.
Great. So you've really touched upon organizational health literacy, the extent to which we, in our organizations, have policies that promote health literacy, do training, and include everybody along the line in health literacy. So that is really important, and thank you for that important reply, and congratulations on that work. So Dr. Vanni, one last question, if we can take 1 minute, and just to sum up, maybe your last important message that you'd like to give, and just leave us with a take-home message, a brief for 1 minute, up to 1 minute. I would love to hear just a closing statement from you, if you're here with us.
Yes. I'm very much here. Yes. So
very brief, and then we will close. Thank you.
Yep. So what we need to look into as researchers, being on this side of the table, we need to think of the other side, meaning the recipients of the questionnaire, our audience. We need to really know them before we embark on a journey. And that is my point number one. Point number two, a health literacy tool developed today may not be very relevant 2 years later. So we should also look forward to finding pathways to revise our own tool and do not keep using something because it's cited well. So this,
Thank
I've
you.
seen this phenomenon when we adapt questionnaires and also when we translate questionnaires. So we need to be up to date on what is happening in the methodological aspects. And the last point, number 3, for my last 30 seconds, is it is important to bridge the gap between quantitative and qualitative research at the same time and ensure that the basic statistical requirements, we try to meet it as much as possible so that our study remains valid wherever we go.
Thank you so much. Yeah, well, that's really important. It's a huge challenge because by the time we publish our new tools, it's already begins to be outdated, and what you've challenged us is with not to just accept every tool that there is. It may be outdated and things are changing very fast in health literacy. So we have to be on our toes and keep our passion going. So thank you both so much. This has been a really valuable session. I also like to thank the organizers for inviting me to moderate and to be in this learning session. And I just look forward to continued contact and learning together. Thank you so much.
Pleasure.
Thank you, ma'am.
And I also, I would like to also repeat what Professor Tintin mentioned. I put in the chat the website for the second Global Summit on Health Literacy. We'd love to receive your abstracts and love to see you at the summit in September. Thank you all so much. And over to you, our host.
Thank you, ma'am. With this, the panel discussion has concluded, which brings us to the end of this session. Thank you all of you to join us. It has been such an honor to be a part of a wonderful event on the behalf of MHLU and Monash University, Malaysia, and the University of Haifa Clet Health Services, Israel. I would like to extend my heartfelt gratitude to our esteemed speaker, moderator, faculty, staff, and student of MAHE, members of MHLU. In the end, I extend a heartfelt thanks to Dr. Asha Kamath, in charge of Prasanna School of Public Health, MAHE, Manipal, administration of MAHE Press, media, and all the support we have received. I have not mentioned the names, but many thanks to everyone of you who has contributed directly, indirectly in the conducting of this webinar. Thank you all.
Thank you very much, Diane and Tintin. So, Professor Tintin, so thank you so much for being here with us.
Thank you.
Thank you, Professor Wani.
Bye-bye. Thank you for organizing.
Yeah, take care. Bye.